Mr. Chairman, ladies and gentlemen, thank you very much, the Society, for having given me the opportunity to talk here. Regarding disclosures, these two companies were involved in the development of this transanal trocar, and I have been working as a consultant for them. I also have to thank, per accident, the two chairmen who gave us in around 2008 the idea, our group, of using the transanal pathway to perform colorectal resections and in the NOTES era, and we had at that time a big experience on TEM and TO operations, and so we did first experimental work and then created this technique which we published in a pilot study a few years ago, and now our objectives were, based on the pilot study, to establish this transanal hybrid colon resection in a clinical routine in our department, evaluating possible indications for an optimal safety record of the patients, select the patients, of course, in this initial experience, and explore also the different indications for the possible benefits, of course. We selected three patient groups that we recruit from mainly from our interdisciplinary center of pelvic floor disorders with our gynecologists and urologists, that is colonic inertia, and then rectal prolapse and chronic sigmoid diverticulitis patients that we see regularly, and these were the indications for selecting these patients. We stayed with the selections with a BMI lower than 30 in order to have better conditions during this technique. We saw these groups of patients. In total, we saw 82 patients, and as you can see, for the main chief complaints of the patients for the colonic inertia was, of course, constipation, also for obstructive defecation and rectal prolapse patients. In the patients with chronic sigmoid diverticulitis, usually these patients had over years a number of different episodes of pain and constipation, and then finally were decided in our group to have a resection. The technique is based on the fact that we use only for the working activity 2 5mm trocars abdominally plus the camera port, and anything else bigger than 5mm goes to the transanal trocar, including staplers, graspers, and any other instruments, and move the anvil of the stapler prior to resection further up in the proximal part of the future anastomotic site, and then open the colon and use all the activity via the transanal trocar. Regarding the intraoperative problems, we encountered finally only in the group with the sigmoid diverticulitis, because of what can be expected, more bulky than expected inflammatory tumors, or the stenosis, 3 conversions, and in one patient a rectal tear, which we had to mobilize further to put the anastomosis a little deeper. Regarding the postoperative problems, we could see that due to the fact that we only used 5mm trocars, wound infection was not occurring, except for one patient that we had a leak, which we had to open revision and then had a subsequent complicated course. In the other cases, we could either go without revision or have a laparoscopic revision. Regarding the more long-term or mid-term effects, regarding our follow-up period of median 18 months, we could see in those patients with subtotal colectomy that we saw a significant increase in quality of life. We saw 2 patients with recurrent constipation over the time of these 18 months. One patient had 1 year after the primary surgery in ileus and had additional surgery. No hernia in that follow-up period was observed in all these cases. neither also in the patients with a resection rectopexy group for rectal prolapse. We saw in this patient one patient with an incontinence, but he had this incontinence, she had this incontinence already 1 year prior to the surgery because of her prolapse that was causing the incontinence. Recurrent diverticular disease occurred in one patient. Again, we saw no hernia in this group of patients. So looking at the quality of life in these patients in the group, on the left bar you can see the normal distribution of the gastrointestinal quality of life index, and you can also see that the quality of life preoperatively in these patients is quite restricted, of around 83, and can be elevated to a level of almost the normal level of 120. If we look at the increase in quality of life, it mainly is based on the improvement of GI symptoms and also of the physical component as well as the social component. Split up in the different indications for quality of life, it also can be stated that the patients with the slow transit constipation or colonic inertia, they postoperatively do not quite get to the normal level because they have further problems with some constipation, but they are significantly improved, while those patients with rectal prolapse where we didn't see any recurrency, or the patients with sigmoid diverticulitis could be significantly improved up until the end. For the discussion, I think the main factor is that we can reduce the number of ports and the size of the ports. Comparing this with a regular traditional laparoscopic surgery, we did only a few matched patients and could see some advantages from day 3 on. There are other reports showing that pain is a major factor in those patients where you use the transanal hybrid approach. This can be also confirmed by another study from Belgium, where the pain medication was significantly reduced in these cases. So in conclusion, I think with these 66 patients that was on the follow-up of 18 months, in the median we can say that transanal hybrid colon resection could be introduced safely in our routine program. When we select the patients, we have potential of preventing wound infection and hernia complications on the mid and long-term run. Of course, we need comparative studies. Thank you very much.
Any questions from the audience? Can you clarify for the audience what percentage of, or what part of the operation was done laparoscopically or versus transanally, or was the majority of it a laparoscopic operation with transanal specimen extraction or stapler?
The main manipulation is that as surgeons I use my left hand doing an abdominal trocar. I use an abdominal trocar except for the energy device, and that my right hand I use transanally and do the manipulations with the stapler, dissection, grasping transanally, also with the stapling. So I would say it's a split of probably 50 to 60% transabdominal and 40 to 50% transanal.
After this large experience, probably one of the largest in the world.
I'm sorry?
You know, after this important experience, probably one of the most important in the world, why not, Karl, in cancer patients?
Well, we discussed this already several times. We will get to that. What we currently do is we try to get exactly that percentage, you know, down 10% from transabdominal and 90% transanal. For that, we need special instruments, and we work on that currently. So that is, and then again, I'm hesitant because I feel that with the cancer, I sort of, I may not do any dissection compromises, while with the benign cases, I'm okay if I can do certain compromises in the dissection. That's my feeling why I didn't go to cancer so far.
Thank you.
Thank you very much for this great experience.